Okay, our next topic is on cancer screening recommendations, looking at lung cancer screening in firefighters. Our presenter is Dr. Mary Reid, who is the Chief of Cancer Screening, Survivorship, and Mentorship at Roswell Park Comprehensive Cancer Center. In more than her 20 years at Roswell Park, Dr. Reid is a distinguished professor of oncology in the Department of Medicine and a key member of the Roswell Park scientific team that is collaborating with Cuban scientists on CMAX. As Chief of Cancer Screening and Survivorship, Dr. Reid has worked to expand Roswell Park's pioneering lung cancer screening program and develop other cancer screening initiatives within the Institute and in the communities of Western New York, working closely with clinical departments and community providers to increase lung, colon, and breast cancer screening compliance. Please join me in welcoming to the stage Dr. Mary Reid.
Thank you very much, and I really appreciate the invitation to come and talk about our program. I brought some friends with me, and they're actually going to begin, come on up here, and then hand it off to me. So again, thank you, and it's the green button.
Okay. Good afternoon, everybody. Thank you for having us here today. My name is Chris Whalen. I'm president of Buffalo Professional Firefighters, Local 282. And we're here to tell you about our cancer prevention journey that we started a short time ago here in this room. The story really begins when I was appointed to the executive board in 2020. Fortunately for our union, we have a policy where 2 executive board members are on release. What this does is allows me to look at things that need attention that might not get the attention they usually get in the office. One of those things was cancer. Ashley had worked with my predecessor on skin screenings and getting the program up and running. But right around 2020 when I realized that we needed to up our game a little bit. So I worked with Ashley. We saw that there was a seminar, a symposium in Miami, Florida in February. Now, there's 2 things I don't want to joke about, and that's the Buffalo Bills and snow. But February sounded pretty good. So her and I came here to the symposium along with our health and safety coordinator, Joe Marchetti, who's back there. And we were balls of fire after that. We really recognized the need to get this program to where it needed to be for our 700 members. At that point, we came back, we started a cancer prevention committee. We got a lot of stakeholders involved, the city, the commissioners, the deputies, Roswell, and most importantly, our chiefs. We have commissioners in Buffalo, we don't have chiefs. Our chiefs are actual civil servants that are on the line with us. They were very, very important to get on board with this. Without them actually doing what we're recommending through science and through the research was really integral to what we were trying to do. So at that point, we started the initiatives that we're going to talk about today, and I still can't believe that 2 years later that we're here talking about some amazing things that we've done. One story I want to tell, though, is I was here last year as well, and unlike 2022, I left here feeling like hopeless, I guess, would be the best way to put it. I had a totally different feel. I'm listening to the Australian cohort talking about remediating their whole country, and I'm thinking about our firehouses from the 1880s, and it was a little depressing, but my team pulled me out of it, and we're going to talk about some of the initiatives that we brought forth, especially Dr. Reid talking about our lung screening mobile Eddy van, or truck, really, which has really made a difference in my member's life. And hopefully I can finish with the story from one of those members that were screened. So I'd like to transition to Ashley Snowden, who, between her and I, we're going to try to get through this together.
Hi, everyone. I'm Ashley Snowden. In addition to being Chris's emotional support animal when he goes down a sad spiral, I'm the Director of Physician and Corporate Relations at Roswell Park. Roswell Park is a freestanding NCI-designated cancer center in Buffalo, New York. We're not a part of an academic system or a matrix system. Fun fact, we were actually the nation's first cancer center, established in 1898 by Dr. Roswell Park, dedicated specifically to cancer research. We have about 50,000 active patients. We have around 160 beds. We're not a huge facility, but our research arm really fuels a lot of that bench to bedside work that we're trying to do. We're located right in Buffalo, New York, in the heart of the city, but our care network branches out across the footprint of New York State, and we're really trying to provide that access to NCI-designated care across the state. We work closely with MSK, our partners downstate, but it really isn't competitive when there's enough people in New York City to treat. We can really work together and collaborate well. So our program started, one of my roles at Roswell is managing our business partnerships on a clinical side, and the New York State Police is one of our biggest corporate partners, and their first ask of me, was to have Roswell Park be included in the World Trade Center Health Program, because we weren't, and we should be. We're 6 hours from New York City based on our location. We have a lot of 9/11 first responders in Buffalo, and not just Buffalo, Syracuse, Rochester, these bigger cities that went to New York City at the time. Who just really didn't have great access to monitoring and screening the way they do downstate. So instead of utilizing the services that they did have, they had to travel. It was really cumbersome, so of course it was an easy yes for us, we'll do that. The execution wasn't so easy. Working with NIOSH and the CDC through a pandemic wasn't the easiest thing to do, but we did it. And it really opened our eyes, and learning about the program here in Miami and connecting with the Buffalo Fire Department really was kind of the impetus of us starting a program, because we knew that the need was there. We started, Mary and I met and we're like, how are we gonna kind of create this program? So we started with a comprehensive skin screening, because we wanted to really make sure we did something that was inclusive. It doesn't matter how old you are, it doesn't matter what your gender is, especially with dermal absorption rates. Skin screening is really the best place we could have started. We created a really kind of long screening assessment form that we distributed out to the firehouses and throughout the membership to complete, and that went specifically to our derm scheduling team, where they would get an appointment. They would be forwarded on to Mary's team in screening and survivorship for whatever other indications they needed, if they were overdue for their colonoscopy, if they needed a PSA or a mammography. So we really tried to wrap our arms around the department completely. The rollout was a little clunky at first. As Chris mentioned, I worked with his predecessor, and we would just go from firehouse to firehouse and talk about it, and I'm sure all the firefighters in the room can imagine, it's before lunch, it's after a call, and some lady comes in to interrupt you to talk about cancer. And I was not that popular at the time, but we'll talk a little bit more on our panel tomorrow about how we sophisticated that process. But we gave out some information. The QR code that you see on this slide takes you directly to our assessment form, so we tried to make it easy as possible to get everybody integrated. And that's really kind of when the committee that Chris mentioned started. So, we're working on our end on the screening side, but, of course, decon is a big issue too. Buffalo people can be really friendly and wonderful, but a little stubborn and old school. So talking about decon was a little bit tough. So phase one was, Roswell was able to fund a year's worth of wipes and shampoos and decontamination products for the entire city. We created a little pamphlet. These are our Buffalo firefighters here that we made. We distributed them out. The committee was really critical in creating those SOGs, and the chiefs, we couldn't have done it without them, because we can talk about it, but having their chief and the division chiefs talking about the necessity of doing this really helped get everything off the ground. So we rolled that out, the gear washing program, and the city provided the department with EMS jackets that are seen here from one of our press events to wear to events, or to wear to calls where they didn't need to wear their bunker gear. We had great support in this photo. Right in the middle is our CEO, Dr. Candace Johnson, and our mayor, Byron Brown. They've been both incredibly supportive of all the initiatives we've done and continue to be. And phase two, I'm gonna let Chris talk a little bit about. This one's a little bit more recent. I can't take credit for this one.
So a few years ago, we met with State Senator Sean Ryan. We had one working extractor that was over 20 years old in the city of Buffalo for 700 firefighters. If you don't know what Buffalo is like, it's like a lot of other Midwestern cities with a lot of balloon frame construction. We get quite a bit of work. So we worked with Senators Ryan's office to get a matching grant for 4 brand new extractors with all the accoutrements, the drying racks, the drying closets, everything else that will just enhance our program. It's just another step to making sure that my firefighters and my members are protected. We've been talking all day about what's on our gear, and we need to get it off. There's no other way around it, and these units will definitely get us there.
And that really leads us to Dr. Reid's presentation. We're going to sit down and she's going to talk to you about really the best part of the screening program, I think, to date that we've initiated.
So with our work kind of with the fire department sort of leading up first to the things that, were immediate remediation of exposure. And then we were lucky enough to get a gift from the governor of New York for a mobile CT unit. That also included support ongoing for staff to man that unit. And it was to screen folks who have access issues to lung cancer screening. And I would include firefighters in that. This represents sort of our catchment area. We go from the northern border, Niagara County, Orleans County, where there are mostly volunteer firefighters, although the city of Niagara has a workforce of about 75 to 100 professional firefighters. Then Buffalo and Erie County, there's again just over 700 firefighters. And down in the lower counties in purple, which is really the northern border of Appalachia, we have 2 cities that have fire departments. And our commitment was based on our government affairs negotiator, Jim Kennedy, to screen firefighters and to work with each city, and we would not charge them. This is a bane of my existence right now from our legal team, but we felt that at least getting a baseline scan for everyone was going to be important. The eligibility for lung cancer screening is that you have to be between 50 and 79. You had to have at least 20 years of active smoking. You had to be an active smoker within 15 years. The guidelines have been changed a few times, but they were changed to capture more women and minority smokers who we know are different than men smokers. And it's currently accepted by most insurance companies. Once you have something that they want to follow, then they start making people have copays. And that is still a work in progress. The majority of firefighters aren't eligible for lung cancer screening according to the guidelines. So if you take people who are high risk and you're having problems negotiating to get them screened, you can imagine what it's like to negotiate to get firefighters screened who don't really, the current firefighter now does not have the smoking exposure that most of the retirees had. So we got, this is Eddie. This is a stress ball, which I've gone through about 3 of them in the last year getting this thing up and running. We brought some in case anybody wants one of these. There's a QR code that takes you to a sheet where you can determine your eligibility. So this is Eddie, and it's I wanted a Winnebago, and I got a 43-foot trailer. But there's a brand new CT in there. We have a clinical team on there that does shared decision-making, talks about smoking cessation, and gets a good look at people coming in. We've just finished our first year, and that's the data that I'm going to report on. But it's really important that we have a mobile unit, because for the general population, and especially in Buffalo, where we have neighborhoods where there's really poor access to screening and there are a lot of barriers, and then we have all this rural, the majority of Western New York is really rural, where people have to drive an hour or two to get to a CT that actually does lung cancer screening. So having a mobile unit was the greatest way to get outreach. But for the firefighters, we decided that as we kind of came to an agreement on that we were going to screen them, we realized that they also have really big parking lots, and they're embedded in the city. And this is really an important factor, because no matter where we go in our catchment area, there's a place for us to park the trailer, and that's usually at a fire hall. The charge of the mobile CT program was to reach underserved populations, and we focused particularly on high risk, which we consider to be firefighters and first responders. We really have a lot of World Trade Center responders in our area. To look at HIV positive survivors, lung cancer is the second most common cancer. They also have a very high smoking rate, and so it was to really engage that community to get them screened for lung cancer. And then other high-risk industries that we have around Buffalo. We don't have steel anymore. We have a lot of survivors of steel, but we also have a lot of people who work in wood and gravel and sand and things like that. And we focused our clinical program to make navigation so that if someone's eligible or they're a firefighter, we essentially take them on a warm handoff from the community onto the bus. And that is really important. We talk to their primary. And I would just say that among firefighters, you get these annual exams. That information does not go to their primary care doctor. For the most part, it's in a black hole. It verifies that you can, wear the gear and you can perform, but it is not information transferred to the primary care doctors who look at the whole patient. And so we really have a strong relationship, because we knew once we started to screen, we were going to find stuff that's not cancer. And we're cancer, and we were going to find cardiovascular stuff. We also wanted to make it really easy that if we did find something, they don't have to come to Roswell. They don't have to be on the bus. We wanted to send people, including firefighters, to a local screening center so that they could get the follow-up they need. And some, and I'll show you, need it in 6 months or 3 months. And so we don't want them chasing Eddie around Western New York. So in terms of low-dose CT, I've been working with lung cancer screening for most of my career. It is really the most effective cancer screening that we have. It is, more effective than mammography. It is more effective than colonoscopy. And in the long run, lung cancer is the biggest killer, and it can really change how many cancer deaths we have a year. When you don't have lung cancer screening, 70% of lung cancers are late stage, and the survivals are terrible, and they have been terrible always. If you get it early, and lung cancer screening will pick up 70% of lung cancers early stage, you can have surgery and you can have cure. Not everybody, but again, if you have a lung cancer and you can live for 20 years, and we have examples of that, then that's essentially turning cancer into a chronic disease, and that is, as far as I'm concerned, a win. If you pick lung cancer up early, you save, it's 10 times more expensive to treat someone at late stage, and the outcomes are not great, as opposed to treating them when it's in early stage. It's still not cheap. And we heard about that earlier, but it's less expensive. And they also pick up other things which are really relevant, I think, for firefighters, that you can pick up plaques, you can pick up abdominal aneurysms, you can pick up asbestosis, which we know exists in especially some of the older firefighters, other lung diseases like COPD. Before you have clinical symptoms, you can find it on a low-dose CT, and you can pick up other cancers, including breast, kidney, you can get lymphoma. And we do that especially among the high-risk people that we're screening. So I'm just going to skip through this because I'm like the fourth person to show this picture, which, you know, to me, as an epidemiologist and in cancer screening, when I talk, I am not talking as if firefighting might be a risky occupation in terms of cancer. It is. It's been confirmed. It's got much better evidence than we see in most things other than maybe smoking. But it's clear, and the talks last year were so great for me to really look at what the outcome was from the IARC publication, and that these cancers make sense to me in terms of where you would see the genotoxic damage, where a lot of carcinogens are processed, and obviously mesothelioma from the asbestos exposure. But these cancers make sense in terms of these are the ones most likely to show genomic damage. Now, you know, these are just taken from a variety of papers, and a lot of it came from the IARC. I would say that lung cancer is not really on the list. And that also makes sense to me because it turns, you know, the exposure that you're going to get from firefighting is going to turn on a chronic inflammatory response in the lung. And that takes a really long time. You know, it's not, even among smokers, it can take 20 years of lead time before you're going to develop that cancer. And I think now that we're really focused on lung cancer in firefighters, we're going to start to see those papers emerging that have really been able to follow them long term and pick up those lung cancers. And hopefully they're all going to be small. I will say the fire makes a difference, and you know, I hang around with firefighters. We've had some particularly bad fires, a chlorine fire on Niagara Street several years ago, and out of that cohort of 230, we've had at least 4 brain cancers, which is, you know, impossible, but it's most likely related to that exposure. We've also had other cancers, but particularly 4 brain cancers, so we are going to be writing that case study up this year with our head of neuro-oncology. So these are videos that'll be in the presentation. I don't want to show them because they never seem to work, but just in terms of some of our PR-produced information at Roswell about firefighters. So the results of year 1. So we have screened 767 firefighters so far. We've also, because we park at the fire hall, the firehouse, sorry, I've been a million times corrected. We have also gotten 300 people from the community who live around those sites, and the majority of these are from Buffalo. We've also gotten some asphalt workers, and then specifically in our HIV positive cohort have gotten on the bus. It's a relatively small number, but it's a kind of a heavy lift population. So this gives you a little bit of some racial breakdown that we see about what we would expect from the city of Buffalo. We have about 14% of our firemen have been African American. They're mostly male from the fire department, and it's about half and half from the community. Not many well, I want to say that there are some firemen who did not show up for screening. And out of the 40 that didn't show up, 38 of them are smokers. So we're really going to work on that. But we have just a few, 5% are current smokers, but 20% overall. And this is a modern, relatively young department, have a smoking exposure. You can see in the community, 64% of the folks who showed up are active current smokers. And among the HIV group, and we see this on the ones who come to brick and mortar, that again the majority of them show up. These are people who smoke and they're concerned and they want to be screened, and that's great. Pack your exposure. So again, the community is heavily exposed. They're committed smokers, whereas it's a relatively low exposure among the firefighters. You can see across the board, and this is not atypical of Buffalo, that a lot of people have family history of cancer. The majority of them are solid tumors. and only 1% of the firefighters have a personal history of cancer. So this is looking at the lung-rad score, and this was developed by radiology. Essentially looks at what you find on the CT, and it provides information on when should this patient be followed, and if they do have a nodule, and that's sort of the precursor lesion that we pick up on low-dose CT that could develop into a lung cancer. So 1 and 2 means that it's essentially normal, but a 2 means that you have some very small scattering of stuff within the lung field. The last column on the right is what we would expect to see based on a 50,000 person study and that converted CTs into lung rads. So, for example, 71% of firefighters don't have a completely normal low-dose CT. They have something small. It has a very low risk of being a lung cancer or progressing, but they're not normal. There may be a scattering of basilar lesions that's picked up. So we would expect 45% of them, and we're getting in the 70s. Okay, so again, I think this is why we're screening firefighters. Lung RADS 3 means you have something that's big enough. Those folks who have a lot of risk factors and who have a lung RADS 3 are 8 times more likely to progress to lung cancer than somebody who doesn't have risk factors. And again, firefighting is a risk factor. So 21 of the firefighters screened, 3%. It's kind of low compared to high-risk lung cancer people, but still a total of about 30, and we know we picked up a couple more last week, need to be followed. Like, they have to come back at least 6 months. The 4As have to come back in 3 months. If there's any change, they have to come back next month or progress to having a biopsy. 4Bs are only 2. Those are highly suspicious lesions. And the reason we built the system from a clinical management standpoint is because those folks have to come in on schedule, and if there's any change comparing to the last CT, they go on for biopsy or surgery. And I was speaking with Jean Comeau from Central Mass. She has a very similar, dogging those screening those folks in the screening program, and she screens in a comprehensive way firefighters, is that they cannot miss their follow-up appointments. So we do not know what low-dose CT looks like in a normal, healthy, free-living population in Buffalo. But I would say that this is giving us food for thought, because you would not really expect to see about 40 healthy workers needing aggressive follow-up for nodules. We picked up one neuroendocrine tumor in a firefighter, and Chris will talk a little bit more about him. So just to put it in perspective, it seems like, well, you screened 750, so you got a lung cancer. So in 50-year-olds with a 20-pack year history who smoked within the last 15 years, I'd have to do 5,200 CTs to save one life from lung cancer. If I took the highest risk category of people with 40 or 50 or 60 pack years, COPD, family history, that kind of risk modeling, I have to do 161 to save a life. And so here I had to do 750 to save a life from lung cancer, which is not what we should find. And as we go forward, we'll see if that was strictly an accident, by chance. To put it again in perspective, you have to do 1,300 mammograms in a normal risk group of women to save a life from breast cancer. So again, if this kind of trend holds out, then we're seeing an increased risk, and it's not documented. And so programs like Jean's and mine and some of the research studies you're doing here and in Boston are the ones that are going to clarify really the risk of lung cancer in firefighters. And I'll just say one more thing. I only have 2 more slides. 59% of firefighters had something outside of the lung. We would expect about 10%, and they were right on track. These are a kidney lesion, a lot of coronary plaques. We called one primary and said the the plaques are so severe that they should not go back to work. They need to see a cardiologist, and we've done that a couple times. So again, it's working in this group, and we're finding stuff, and we're following up, and we think that even from that, we're saving lives, not from lung cancer, but from a coronary event. So in summary, a mobile unit can accomplish your goal of screening firefighters, and we're doing it both in small cities and in large cities, and we're utilizing the parking lots at the fire halls, because that is a great way of doing it. We got people off time or off the clock so they could come and be screened. Took us a bit to figure that out. Firefighters are a high-risk cohort in my book, and I've been doing this a long time. They're certainly higher than those 20-pack year 50-year-olds who are being screened. But they require long-term surveillance. So none of those 40 can drop off. They have to all be followed with repeated scans. We require protocols, standard protocols on who should be screened and at what frequency. The president of the American Thoracic Society, Patricia Rivera, who happens to be in Rochester, we're starting a little task force. I talked with Alberto to be on that task force to talk about what is the schedule that we should push to really screen firefighters. And it, of course, will be based on years of service, but that alone is not enough. We have to learn more about the results of CT. The mobile unit provides education and awareness, and if someone comes in and they haven't had their colonoscopy, we talk about it, or their mammography, but there are insurance barriers. There's no question about it. And on the state, the state level, we need to address that for screening. And we're working hard to get better guidelines for people who've had firefighting as an occupational exposure. We need to have a cohesive strategy to pass legislation. And we have government affairs, we have the American Cancer Society, the American Lung Association working with us, but you really have to make it through the state houses to get something meaningful for firefighters. And obviously, and the folks down here know this, that this is an opportunity for research to, now the next step is to get a little mobile lab where we can draw blood and take nasal swabs and do some other sampling that I think is going to increase our knowledge about what actually happens to firefighters over time. That's my team. It takes a lot of people to get these going and to collect data, and I'm very happy at our success. So I'm going to turn this back to Chris.
Thank you, Dr. Reid. So now what? Before I get to that, I have to tell a story that pretty much summarizes why we're all here. We're firefighters. We don't have initials after our name. Sometimes when we're in a room like this and a guy like me standing up here terrified, I notice that difference. We're a little wary of outsiders, but once you bring us in and you prove that you got our back, we are going to be welcoming, and you're going to become part of our family. And that's what's happening with Roswell Park and the Buffalo Fire Department. A few years ago when we were starting this program, a captain of the rescue was having back surgery because he was injured on the job. They took a CAT scan of his back in preparation for the surgery. Now, a couple years later, we start this SETI initiative, and he is given a scan. The nodule that was there in the previous scan had either grown or I don't know the terminology, but it was different. Enough so that it was explored, biopsied, and it was removed as stage 1 lung cancer. So Dr. Reid had talked before about how they had removed those parameters. To me, that's the first step. And she even described lawyers giving her grief. So, I kind of enjoy that. But it really was the first step in them having our back. The next step was New York State does not have lung cancer as a presumptive cancer. As president, we need to get these classified as on-duty injuries. We made an application to have it classified as such. This captain had been on the job 27 years, multiple acute exposures, over 1,000 structure fires, captain of the rescue for 15 of those 27 years. He recovered. He came back to work. This is how it's supposed to work. Dr. Reid, after the city pushed back on classifying his cancer as an occupational disease or injury, stepped up and wrote a letter stating through the personal factors and the literature that's out there that his cancer was more likely than not caused by his job. His injury was approved, and I believe it's the first one in New York State to have that status granted to it. It was a big deal in our department. I can't say enough about how that showed that these people are going to step up for us. Everyone on the fire department knows their names, and rightly so, because Captain Mark Egloff is alive, he's back at work, and he's home with his family. So now what? As long as that keeps happening, that's good, because that's why we're all here. Thank you.
Dr. Reid, Ashley, President Whelan, I don't know if you remember, Dr. Reid, you shared with one of these with me last year, and I have it on my monitor in my work computer. So I think about you and Roswell and the amazing work that you're doing with Buffalo Fire there. It's amazing. Thank you. Questions from the audience that you would like to ask? Coming up. Use the microphone if you would.
How long does it take per person to get the scan?
So there's about 4 minutes to counsel the person on shared decision-making, which is a requirement by the center, by CMS. And then the scan itself is 3 minutes. So it takes about a week to get the results back to them with a treatment plan on what their follow-up should be.
Takes an extra minute to make them take their turnout gear off, too. That's a
You got to add
requirement.
that one, yeah.
That's a requirement.
to turn off the turn off gear. Any other questions? Go ahead, please.
I think there's over there, too.
I'll come grab that one. Yeah, let me do that one, and then I'll come back to Chief Eaton.
Thank you.
Oh,
Is it on?
Yes.
yeah.
So my name's Doug DeMolin. I also research firefighters as well. Branching out into more of the cancer, but I think juxtaposing behavioral health and cancer, it's comparing to the veteran population. So when I say that in the aspect of cancer, there are these claims with veterans getting cancer with burn pits. And it's linking that with the firefighter occupation because it's combustible material.
Mm-hmm.
You're exposed to it, veterans are exposed to it, they're getting claims, why aren't the firefighters? And that's their whole job. And so you look at it in the behavioral health aspect where you got PTSD, moral injury's been a huge topic, and now firefighter research is like a decade behind when it comes to veterans. And I think when it comes to cancer, that's the population we need to compare to.
So I don't disagree with you. And, lung cancer is about 20 years behind breast cancer screening. So I feel your pain. It's, there's a new big initiative for vets who are actually eligible, many of them, for lung cancer screening to do screening. But it's, the thing with the burn pits, it's more like a World Trade Center exposure and not a chronic, over a 20-year of working exposure. So it's really different, just like how people smoke is really different.
It's the burden of proof.
Well,
Yeah.
I think, there's a lot more people at this conference this year than there was last year. The synergy, at least in our state, and we have a very complicated political state.
She's serious.
Not that we know it, but, it is building momentum. And so we have to really be positive that it helps to clarify that this is not a burn pit exposure. This is probably, a 500, we were trying to figure out how many fires he's been to. It's like 500 small burn pit exposures. And we know the use of gear during the fire has changed over the years. So it's really a different exposure, and it's going to generate cancer at a different rate, and it's going to generate different cancers. But I mean, I don't, the vets don't have it easy in any way. Oh, no, for sure. But I think now we're beginning to all talk to each other, including the person who does the litigation. That's hugely important, because nothing speaks louder than lawsuits, in my view. The burn pits were something everybody could see. We watched them. When they invaded Kuwait, we all watched it on TV, and we did the same. And so I think that has a factor. But, the momentum is building, just like it is for lung cancer screening. This is kind of the moment where we go all out, and we don't take no for an answer. And just, even if we do incremental steps, we are moving forward, but we have to do it on many different levels.
Amen. Chief Eaton?
Thank you. Congratulations. I love the name Eddie, by the way. That's very cool, very crafty. Sam Eaton, retired Palm Beach County Fire Rescue, currently with the Florida Firefighters Safety and Health Collaborative. I have two questions. One is your screening for the department, is it mandatory? And if it's not, what's your percentage of coverage, so to speak? Where are you at with that as far as getting the department covered? And the second question is on retirees. How are you handling that demographic?
Take the first part.
Okay. So the great thing about it being mobile is it's coming to the firehouses, as Dr. Reid said. Fortunately, we had made enough headway with the membership that they could buy into taking a short walk out of the firehouse to the trailer and having their lung scanned. So that portion of it really drove participation. There's no doubt about it. If we put it on the members themselves, I would say probably half, if not less, would have availed themselves to this amazing diagnostic tool.
Yeah, I just wanted to add, before this was offered mobily, and we were able to work with the city to take members off duty for an hour for screening, when it was just a skin screening or a comprehensive screening, we had probably through Buffalo and Niagara Falls departments, maybe 250 members that got screened, and that's out of almost 900. But when we brought it to the firehouses, we allowed them to use their time to come do it. The compliance was close to 90%. So that's why the mobile unit really was so important, and we want to continue to be able to do the BioBus and do more screening, on site, because the compliance rate is, incredibly higher.
And that was, I'm sorry, Mary, just one quick thing, and that's where, before I mentioned about the chiefs, they were completely on board in scheduling those screenings and making sure companies could go to that location in that battalion, go out of service for an hour while the 4 guys got screened. So it truly has to be buy-in from everybody. Mm-hmm. But when you have people like Ashley and Dr. Reid here from Roswell, it's caught a hold of our department, and I think any initiative we put out there will likely be well attended.
Okay, last question before we head over to break. So, yes, sir.
Okay, so
Oh,
one thing
Second
I
part.
checked out when it was said earlier, so the retirees from Buffalo Fire are covered under the same health care. So their health care extends into retirement. But we are going to focus on them to either over 45 with 20 years of experience. We will be able to do that annual scan. But with retirees, we really will focus on people who are eligible based on the guidelines. With some, they don't have to have smoked within 15 years. But they do have health coverage as part of the city arrangement with them, which I think is a really big benefit. So if they do get cancer or they need to pay out of pocket for something, they do have coverage. So it's not perfect, but I think at least it gives us access to them.
Okay, our last question. Yes, sir.
So the plaques and aneurysms and breast cancer on the side, if I send my guys, I'm in charge of our annual physicals back home. It's not embedded in our program to have the CTs. I'm kind of looking into that.
Yeah.
If I send them to their regular doctor to get a script for a CT, is their doctor gonna do the same kind of looking at it as y'all would? Or do I need a certain physician to write it a certain way?
No, I think you'll get a script, you'll go to a radiology center. That radiologist is going to do exactly what ours do and send the results back to the provider that wrote the script, which is really important because it must be their primary care provider and not the annual physical group, because they don't put that information in to the health exchange, they don't give it back to your primary. If you have a nodule as a firefighter and you're supposed to come back, you have to come back. Otherwise, don't do it, because you'll miss those nodules that grow. So the person who's writing the order will get the report, and it should be their primary care doctor. And that means the whole person is seen, they understand that they're in increased risk, they'll get the radiology results, and they'll be able to schedule them for the next one, whenever that is. So it's really important to get it into their health realm.
Thank you.
Sure. So we're around and happy to talk, and if you want an Eddie, we'll be carrying them around in a bag, so we're happy to give you one. Thank you very much.
Thank you.
Thank you.